Good evening, all. I hope all of you are safe during the present circumstances. On the behalf of IDEA Malabar, I welcome you all to the 27th CDE. It is our 24th webinar. Next, I would like to invite our President, Dr. Shaju Mandoli, sir, to say a few words.
Hi, everyone. We are the 27th CDE. Lockdown കാലത്ത് നമ്മളിപ്പം ഇത്രയും പ്രോഗ്രാമുകൾ നടത്തി കുറച്ചു കാലം ചെറിയൊരു ലോക്ക്ഡൗൺ ഇതിലും ഉണ്ടായി എന്നാൽ നമ്മൾ അഗൈൻ റീസ്റ്റാർട്ട് ചെയ്തിരിക്കുകയാണ് ഇനി രണ്ടാഴ്ചയിലൊരു എന്തായാലും ഒരു CDH നടത്തും ഈ ഒരു സബ്ജക്റ്റ് നമ്മൾ തുടക്കത്തിൽ തന്നെ എനിക്ക് തോന്നുന്ന ഒരു ആദ്യത്തെ ഒരു 2-3 പ്രോഗ്രാമിന്റെ ഇടയ്ക്ക് നടത്തണമെന്ന് ഉദ്ദേശിച്ച പ്രോഗ്രാം ആണെങ്കിൽ ഡോക്ടർ നമിതയുടെ ഈ ആക്സസ് ഓപ്പണിംഗ് അത് എന്തുകൊണ്ട് നീണ്ടുകൊണ്ട് പോയി എനിവേ സമയം നീട്ടുന്നില്ല നമുക്ക് പ്രോഗ്രാമിലേക്ക് കടക്കാം ഇഷ്ടംപോലെ ആൾക്കാർ വെയിറ്റ് ചെയ്ത് 120 ആൾക്കാർ രജിസ്റ്റർ ചെയ്ത് വെക്കുന്നുണ്ട് ആരും പുഷ്പിക്കുന്നില്ല നമുക്ക് ക്ലാസ്സിലേക്ക് കടക്കാം ഡോക്ടർ നമിത യു ക്യാൻ സ്റ്റാർട്ട്
ഞാൻ ഡോക്ടറെ ഒന്ന് ഇൻട്രൊഡ്യൂസ് ചെയ്തോട്ടെ ഡോക്ടർ നമിത ദിവാകർ graduated her BDS and MDS from Dr. MGR Medical University, Tamil Nadu. She has led quite an eventful academic period and has actively presented many papers at many venues, out of which she has achieved Dr. C.R. Saraswati Medal for the Best Student Scientific Paper Presentation at National Conference of ISDR in 2011. She has presented the best paper at National Conference IES 2012 at Dubai also and has won several other accolades also. Next, I invite Dr. Namitha Divakar to start her presentation.
Thank you, Dr. Unikrishna. Good evening. I am Dr. Namitha Divakar, reader, Sree Anjaneya Institute of Dental Sciences. And on behalf of IDA Malabar and WDC, I'll be giving a short lecture on access cavity preparation in endodontics, which I have tried my best to present to you in a simplified manner. Uni Doctor, can you please let me share the screen?
Right. Yes, ma'am, we can do it. Go ahead.
Access cavity preparation in endodontics. Our last webinar was on rubber dam by Dr. Shibu Sridhar, and in that he had stressed the significance in rubber dam, significance in the use of rubber dam, especially in the current scenario of COVID-19. And rubber dam, along with antiseptic mouth rinses, helps in controlling atmospheric viral contamination during endodontic procedures. And so, before we open access cavities, hope our rubber dams are on and intact. Our topic will include some important steps and some tips to guide you in your routine clinical practice and in access opening of teeth. We will definitely not be going into details about modified versions of access cavity preparations, or as it will be another big lecture topic itself. So let's stick on to our current topic, which I do hope will provide you at least a bit ease in your current scenario of root canal preparation aspect while practicing endodontics at clinic. A standard lecture in this topic would definitely begin with the sentence, as you see on the screen, like adequate access is essential for successful endodontic treatments. Now, what is this adequate access? What can make it inadequate? Or rather, what is zealotic? Access cavity preparation in endodontics is a vast topic. We can go hours on this. I can obviously bore you to tears, maybe in an hour or maybe even half. So we will touch 10 important areas in access opening. I'll go point wise. And to remind you once again, this is not this is not about the modern preparations or the complicated access cavity preparation. This is just practical points on the routine access cavity preparation that you face in your day-to-day practice. The ideal access cavity usually shows identifiable canal entrances at the base of a large pulpal floor. Here, as the case with any medical disease, our tooth is also in a diseased stage. How do you say a patient is COVID positive? Do you say that if the patient has fever, sore throat, headache, a runny nose, loss of taste smell? No. You either do a molecular test or a serological test like PCR, antibody test, antigen testing, etc. Likewise, the patient has complained of pulpal like pain, or maybe the caries is deep enough to cause pulpal involvement, or other reasons for root canal treatment, but you really don't know the condition of the tooth, the extent of destruction, periapical involvement, periradicular distraction, long-term age-related changes the tooth has undergone without having a pre-assessment done using radiographs. So that's where actually we begin the topic, radiographs, a must in endodontic practice, or rather an imperative requirement. I have an appeal to all the clinicians and the future clinicians attending this lecture to kindly take an IOPA at least pre-operatively for basic assessment before even giving the patient an option for root canal treatment. There are actually certain clinics where I used to go as consultant and the patient has already paid 1/2 of the total money of root canal treatment, or maybe fully ready to even place a zirconia crown, confident that an endodontist would now barge into the clinic and rescue the affected tooth, where I would be the first one to take an IOPA and the unfortunate one actually to send the tooth for extraction when I see some furcation involvement, a fracture, or an for extreme bone loss. That single and proper IOPA will define and determine your access cavity preparation. The term proper can be misleading, so I must say an ideal radiograph. An ideal radiograph will give you so many details, requirements, so many things, but I'll say it should have some amount of desired density, some amount of contrast, and definitely it should cover the anatomic area of interest from top to bottom. There are now conventional and specialized recent type of imaging systems available right now, but leave all that. Under normal circumstances, and as far as normal root canal treatment is concerned, a dentist should not consider dental panoramic radiographs and other high radiation radiographs as an alternative to intraoral projections. We don't want to treat icebergs in our clinic. Even if we should know the depth of the scenario, so that I would say take IOPA at 2 different angulations at least to assess 70% about our concerned tooth. 2 different angulations will definitely give some light to what you're going to face. A proper coronal axis forms the foundation of the pyramid of this endodontic treatment, and this is called the endodontic triad actually. So if your base is weak or wrong, your entire procedure of root canal treatment is going to go wrong, and it can impair your instrumentation, disinfection, and obturation, resulting in poor prognosis of the treatment. So radiographs actually help in knowing morphology of the tooth, anatomy, number of canal, curvature, length of the canal, so many things, and position and size of the pulp chamber, as the distance from the occlusal surface, position of the apical foramen, calcifications, all. So these are the very few uses of radiographs out of many, which makes this step one of the most important one before beginning our venture. We go to the second point, instruments. It is essential to have the best instruments, but it is also essential that the instruments be used in the right way. A good instrument actually improves the way you work. So we are talking mostly about the burr. Any good textbook you take or any standard journal you take, they have given at least 2 types of burrs for access cavity preparation. They are axis opening burrs and axis refining burrs. Axis opening burrs are usually round burrs. Mind you, these have slightly longer shank than the standard burrs. It is a very important point because with the normal round burr, you will find it very difficult to reach the roof, feel the plunge or the dip, and your visibility is definitely going to be an issue. You will have to strain your handpiece or your aerotor, and you will have to strain yourself so much to reach beyond the dentine, and in that strain you might not even feel the burr drop. So my first point of advice will be definitely to use an extended shank round burr for initial entry into the tooth. It definitely prevents over preparation. Other normal round burrs are actually used for caries removal and removal of other defective restorative materials. And in the first picture, you have seen an LN burr. This is a long neck burr. This is a tungsten steel burr, and with a total length of 28 millimeters, and tip length itself is 8 millimeters, so that you have lots of visibility into the pulp chamber. And now there is something called axis refining burrs. These are actually used once the drop-in into the pulp chamber is obtained. Then the round burr is actually replaced by a tapering fishery burr or other refining burrs. Now, axis finishing is best carried out by using these burrs, which are safe and they have non-end cutting. These are non-end cutting burrs actually. Never ever use a tapered fissure burr or a straight cutting burr, end cutting burr, to refine your axis. It is the greatest chance that your axis opening or your axis cavity is going to be highly irregular, causing multiple ledges. See the multiple ledges which are created on the distal wall due to cutting burrs, and may even cause an unknown perforation. We don't know. So do not use them. Two superb burrs which I have come across are the Dentsply's Endo Axis burr and the Endo Z burrs. These are actually quite economical also. It comes to around 400 to 500 rupees per burr, and you can use it in plenty of cases. These burrs are actually less likely to damage or perforate the pulp chamber floor. Now, there is another set of burrs called the Muntz Discovery burrs. Actually, these are carbide endodontic burrs designed to uncover hidden canals. And these burrs are actually latch type and autoclavable. And these are available in many styles. See the names written there: deep truffer, shallow truffer, endocarisectomy burr, and all that. And this has actually been placed in the slide because it has been rated almost 97% good by practitioners, and I must say it is one of the best long shank endo burrs available. Other burrs are Muller burrs. These are again small round burrs with long shank, and LA axis burrs. This comes in the entire kit, and it is designed by Dr. Stephen Buchanan. This kit completes the entire thing. This contains everything, and this has non-end cutting burrs also. And so 2 points down the lane, we'll come into a checklist. The highlighters of this session were: never start an axis opening without a clear radiograph covering the entire area of interest. If possible, please do take it in a separate angulation. If you are using definitely RVG without causing patient greater radiation damage, you can definitely take 2 angulations and you will have almost 50% in your hand. And second point was use an extended shank round burr to open the axis. Axis opening burr and Endo Z burrs are economically available, and never use end cutting burrs. Now we go to the third point of this webinar. We have now opened, we have the instrument, and we have created a cavity. Now that we are inside the pulp chamber, we have to open the pulp chamber completely. That is, complete deroofing is necessary. Check the depth of the preparation by aligning the burr and the handpiece against the radiograph. Again, the quality of the radiograph should be taken into consideration. There should be no elongation and no shortening. Otherwise, aligning the burr against the radiograph will give you completely different ideas. And have a virtual outline form ready, and the burr is penetrated into the crown, and you can complete the outline form. Burr is actually penetrated deep at one point, and which point and everything is discussed in detailedly in the following points to come. And this is just a general thing I'm trying to tell. Burr is penetrated at one point until a plunging, drop in, or a falling into vacuum that feel is obtained. That is, it will be felt when the burr falls into the pulp chamber. If it is a vital tooth, the drop in actually should not be expected at all. Where when the chamber is very narrow or completely absent because of the development of abundant calcifications. And if you're drilling a tooth with a completely calcified chamber, one waits for the sensation of falling into vacuum. It will be too late when it does occur, and that may even signify perforation. Once the drop-in is obtained, move the burr in a lateral direction and complete the outline form with scoop out motions. That is, you're scooping out an ice cream from the container. That motion should be there, and that is from inside to outside. Just scoop it out, and then replace it with the lateral cutting burrs and finish and flare. The opening, actually, in any opening in any tooth, it should be funnel shape. That's what we say. This is a funnel shape, and it should be open towards exterior for better visibility and orientation. And moreover, don't worry about the upper 2 millimeter of the tooth, because the tooth has to go in for crown preparation, and you are going to reduce it subsequently. One good thing you can actually do here is to reduce the tooth occlusally at least 1 millimeter, so that it is free of occlusal forces from bite after root canal treatment. When the patient bites, free them off from severe pain that is caused due to biting after root canal treatment. And the added advantage is that you get a stable reference point also. Access cavity should be cut so that the pulpal roof, including all the overlying dentine, is removed. In this slide, see, you can see the commonly done mistake. Holes are created and access to canals are definitely made, but the roof is still present. Pulp is still present inside, and complete debridement has not actually taken place. And remove all of the floor and never touch the floor is our basic idea. Remove all of the roof. Remove all of the roof and never touch the floor. In this picture, you can see the roof slowly being removed and the floor now being visible. Touching the floor of the pulp chamber will definitely result in weakening of the tooth as such. And there is increased chances of perforating and actually increased difficulty in finding or locating the canals. It is said that by touching the floor with the burr makes identification of canals 3 times more difficult. And the probability that you will miss a canal is also there. That is almost doubled up. So never touch the floor, but clearly touch all of the roof as to remove them. So the deroofing is over, and take out the entire content, permit removal of all chamber contents. See the picture 2, the axial walls are kept tapered. And as said earlier, they diverge from the pulpal floor towards the occlusal surface. And smooth, flat, tapered axial walls actually improve refraction of light and vision. Okay. This is a completed one, and you can see the tapered walls, tapered axial walls, and all the canals visible. All these are actually good to say for a tooth which is hardly affected by caries, or more often maybe a class 1 caries. Where the tooth is heavily restored and has caries involving 2 or more walls, the first principle actually would definitely be removal of all caries and infected tooth material, and also other restorative materials, especially in the path of entrance to the root canals. Removal of all carious matter is essential, so that we need to know how much of the healthy tooth is actually left behind to plan the post and core, if at all necessary. And it is also essential that there is no recontamination or reinfection of the endodontic space. And mind you, caries will proceed if not removed. Now, whatever the caries structure or whatever restorative material you remove, maintaining 4 walls of the access cavity preparation is very ideal. I would say ideal. One, you can actually cut as in a perfect tooth. The orifices and the shape of the outline form would be easier for you to understand if there are 4 walls and the tooth is intact. And second thing, to position the rubber dam correctly. Third will be to keep the pulp chamber constantly flooded with irrigating solution. That is quite important. Otherwise, all the irrigating solution will be leaking out. Then fourth is to have a stable reference point for rubber stops. And lastly, to give a proper temporary filling. In this context, the last point to be stressed is that you have to debride the pulp chamber completely. If you are strategically doing a war, do not leave behind any remains. Any remains left behind will bring in greater repercussions and trouble than what you actually expect. So wipe out. The endodontic space comprises not only the root canal, but also the pulp chamber with its pulp horns. To accomplish the thorough cleaning, it is necessary to completely remove the chamber roof. So the number of pulp horns found within each cusp tube is normally 1 horn per functional cusp. So removing all pulp horns is also necessary. That is, we need not make the access too small that you are leaving behind your pulp horns. And important for 3 reasons. One, contamination of or infection of the endodontic space is a chance. Then discoloration of the endodontically treated tooth, especially the front tooth, is a chance. And the third thing is that the patient can complain you about sensitivity to heat, cold, and all that due to all these pulpal remains. So the importance of ultrasonics, as in the figure 2, and the use of Arden's probe that is being used in the figure 1, and all come here along with the use of hypochlorite. The use of all these things are here, and all these helps actually in debridement of the pulp chamber. Okay, going to point number 4, loss. Now, laws are actually important because it acts as guideline as to what is acceptable and what is ethical. Two eminent personalities were Paul Krasner and Henry J. Ranko. The picture of Paul Krasner is actually shown in this picture. They have laid down some laws to be practiced while doing access cavity preparation of tooth. This is actually beautifully given in JOE 2004, where they evaluated many tooth and proposed all these laws. So all these laws actually help in determining pulp chamber position and the exact location and the number of canals in an individual tooth. We'll go by the laws now. First is the law of symmetry. Okay, law of symmetry has 2 sub laws in that. One is law of symmetry 1. See that it states that except for maxillary molars, completely leave the maxillary molar picture from your mind, the orifices of the canals are equidistant from a line drawn in the mesiodistal direction through the pulp chamber floor. I'll repeat. See the mesiodistal line drawn through the pulp chamber of the floor in red in the second picture. And the law states that A equal to B. That is, you have found a canal in the mesiobuccal direction and a line from the mesiodistal direction. In that, you can actually estimate the distance of A, and if you have not found out B, it is very ideal that there is a canal backwards to it and it will be of the same distance as you got A. Okay, that is, it is a symmetry. This endodontics, the entire access opening, almost 80% of the teeth follow this law of symmetry. You found one canal in the buccal side, there is very much possibility that there is a canal in the distal side. Almost equidistant. Okay. And if you have found one large canal in the distal and it is not crossing the midway, it is very likely that there is no other canal on that other side. This is a law of symmetry too, slightly different from that of the first. It states that, again, this is not for maxillary molars at all. This states that orifices of the canal, okay, lie on a line perpendicular to a line drawn in the mesiodistal direction across the center of the floor of the pulp. The center of the tooth and the mesiodistal line is MD. The picture 1, the figure 2, B figure, that is the mesiodistal line, and you have found out canal 1. It is very likely that the canal on the lingual side be present on the same line which is almost perpendicular to the line drawn in the mesiodistal direction. So 1 you have found out, and the X, definitely it is there on the same line. And you see the distal canal. The distal canal is present there, and it is almost in the middle of the line drawn in the mesiodistal direction. You need not search for another canal below it or behind it. Don't waste your time and don't sacrifice tooth. We'll go to law of orifice location. That is also subdivided into 2 and 3. Law of orifice location 1, it states that orifices of the root canal are always located at the junction of the wall and the floor. Here, what we need to understand is what is the junction of the wall and the floor. The floor is painted black here for easy identification, and the walls are what is surrounding the black area. Understand that FWJ, that is the floor wall junction, has nothing to do with your access cavity walls. We are talking entirely about the floor of the pulp chamber, where you will find the real floor and the walls. Now read the law again. It states that the orifices are always located at the junction of the wall and the floor. That is marked in yellow. It is always located in that junction. We'll go to law of orifice location 2. That states that orifices are always located at the angles of the floor wall junction. See all the angles where it is marked green, all where you can actually find canals. Actually, these both laws can be used to identify the number and position of the root canal orifices of the tooth, because all these orifices can be located along the floor wall junction. Now see this diagram. After understanding orifice location 1 and 2, when you see this diagram, it is very clear that black dots, white dots, other indentations and anything observed elsewhere should be ignored to actually avoid the possibilities of perforation. The orifice location 2 actually will help you understand precise location of orifices. It states at the angles. So even slight deviation in angles also will have to be taken care if we are searching or doubtful about accessory canals other than the main canals. Okay. See the picture of a maxillary molar here. The deviation of the angle to find the MB2, the deviation of this angle from the mesio-buccal canal to the palatal, there is a slight deviation, clearly indicates the presence of MB2. Otherwise, the angle would have been more straighter, like I marked it in yellow. That is not there. There is slight angulation, and definitely there is a greater chance that there is a canal there or more canals. Okay. We'll go to law of orifice location 3, which states that the orifices are located at the terminus of the root developmental fusion line. Understand in this picture that the black colored lines drawn here in the floor actually represent the fusion lines. The black colored line is the fusion line I'm talking about. And the gray colored area. The gray colored area inside the yellow triangle in the first picture actually is the whole of the pulpal floor. So again, read the, I'll be reading the orifice location law. It states that orifices are located at the terminus of root development fusion lines. So at the end of these fusion lines, or where the groove ends, we can actually locate canals. So these 3 laws are observed in almost 95% of the teeth. 95%. Exceptions from this law are seen, but it is mostly with mandibular, second molar and third molar, maxillary molars, as I have already stated, where there is a C-shaped canal and other morphological aberrations. Okay, combine these laws and evaluate more to get a correcter idea. That is, we need not follow law of symmetry alone. We have to combine the law of symmetry and the law of orifice location to actually easily find out root canal orifices. We'll move to law of concentricity. And the term concentric means a circle within one another. This law states that the walls of the pulp chamber are always concentric to the external surface of the tooth at the level of the CEJ. Mind you, at the level of the CEJ, it is not at the crown portion. In this picture, a molar has been sectioned at CEJ, and please see the picture B. The outline form, which is roughly round, is depicted at the pulp chamber wall. It is depicted in white, and thus the tooth outline is almost round, and the pulp chamber wall can never acquire a triangle shape that is like given in D. Don't ever detect it as triangle. If it is round, definitely your pulp chamber wall will also be round. And this is a repetition of already discussed one, the picture B, which shows the outline roughly triangular, and the inside wall will also be roughly triangular with the chances of 3 major canals, and accessory ones may be there in the line of the triangle. Moving on to law of centrality, the floor of the pulp chamber is always located in the center of the tooth at the level of the CEJ. Nothing is there. When we start an access cavity preparation, we'll always get notified, start in the center of the tooth, start in the center of the tooth. That is why we said almost 95% the pulp chamber will always be located in the center of the tooth. Exception will be, slight exception definitely will be the maxillary molar and certain mandibular molar with C-shaped canal configuration. And knowledge of the law of centrality will actually help prevent crown perforations in a lateral direction. So ultimately, CEJ can be used as a circular target, regardless of how the non-anatomic, the clinical crown or restoration be. You have confusions with the clinical crown, it is very normal, but CEJ will definitely be the primemost and reliable landmark for locating the pulp chamber, even if the clinical crown has been badly mutilated by caries, trauma, or any other reason. Okay, this opens for the law of CEJ, which states that CEJ is the most consistent and repeatable landmark for locating the position of the pulp chamber. Just as the neck is important to us dentists, CEJ is definitely a big daddy in endodontics. Gentle reminder to all the practitioners out there, neck pain, if left untreated or unattended, can lead to disability or even early retirement. You can choose what you really want to. So the neck is important, so is CEJ. The last law is the law of color change. The most identifiable one and the most easiest of all, I guess. It states that the color of the pulp chamber floor is always darker than the walls. Obviously, it can be seen there because this dark light junction is always there in any tooth. If it is not seen in one portion of the floor, it should be immediately recognized that the additional overlying structure must be removed. That additional overlying structure actually can be pulp chamber roof, restorative material, or a reparative dentine. Okay, so with this, we have actually finished the laws in endodontics. Going on to straight line axis. Complete straight line axis in endodontic axis. Complete straight line endodontic axis actually influences and simplifies all subsequent instrumentation procedures, while virtually it eliminates all frustrations regarding cleaning and shaping. This axis guarantees a more direct initial path for the instrument, leading it towards the apex. Now, a perfect axis is neither too large nor small. I understand all that. Now, put it straight, I can definitely point out some uses of a straight line axis. We'll see what we do. We can see and locate a missed canal easily. We'll have enhanced irrigation, debridement, and minimum possibility of acute file bending, minimum possibility of file separation ledges, and so many other errors. See, it saves lots of time for the consultants and busy practitioners. So actually, if a file enters the canal easily and maintains a straight line position with the long axis of the tooth, then you know that the axis is correct. Okay, the endodontic instrument should never actually touch the wall of the pulp chamber. They must actually be able to work on the entire circumference of the canal. An access cavity that is too narrow will actually force the dentist to work on only one side of the canal, and other will remain completely untouched. And deformations of the apical foramen all will definitely result. Secondly, the friction associated with the instrument shaft against the coronal obstruction will have to be overcome. That is, a force required to do so impairs endodontist's ability to sense how much the working portion of the instrument is engaged in the canal wall. That is, this could actually easily lead to fracturing of the instrument. Okay. The force or the friction locked in the lingual canal can definitely make the lingual instrument separate, and that separations can be shown or can be seen at varying positions due to inadequate access opening. Just imagine in the first and the second picture, the practitioner has managed to open the axis and even send a instrument in, but unfortunately it has separated. So maintain a straight line axis. It will definitely save you lots of frustrations and time. Moving on to the 6th point, the shape of the axis cavity. I actually believe in the school of thought that the axis cavity must not assume a predetermined geometric shape. It is the anatomy of the pulp chamber floor which determines the shape of the cavity, not the clinician. And furthermore, axis cavity need not necessarily be unaltered. See, I have to follow a triangular shape and I will not deviate from it. There is no stringent protocols regarding that. And this is actually where the knowledge about the tooth and all that comes into play. Because I do believe that our eye will recognize what our brain knows, and I will see only what I want to see. I will not see what I don't know. So generally, it will really follow a shape. I again repeat, generally. Our eyes and brain should actually be sharp enough to categorize something as exceptional or as something different. We'll move on to individual tooth axis cavity shapes and procedures. Upper central incisor and lateral incisor, I'll take it together. Both the teeth are about 20-21 millimeter average length, and it will have a single long canal. So axis cavity is started at the point just occlusal to the cingulum. See the cingulum and just occlusal to the cingulum. This is a maxillary tooth. That is why I said occlusal to the cingulum. And the burr is kept almost close to 90 degree to the palatal side. And cingulum is actually kept as a reference point here because this ridge remains constant throughout a patient's life, if unaffected by caries or other etiological factors. Okay. The burr goes deep for almost 3 to 4 millimeters and then the drop is felt. Once it is felt, the next job is to remove the two triangles which is shown in the picture 1. Triangle 1 and triangle 2, these are essentially ledges. And these two triangles actually interfere with the introduction of endodontic instruments so much. And the triangle 1 is mostly made up of enamel and triangle 2 is mostly made up of dentine. Take out the burr from inside out. That is again I'm trying to tell you, scoop it out and remove all these both blocks. And with the removal of these triangles, with a slight mesiodistal movement is imparted to the burr to remove all of the roof and refining the cavity. The axis cavity again almost roughly attains a triangular shape. See, the only difference with the lateral incisor here is that the shape is more ovoid. And suppose that is the only difference which I have noted, and it is slightly curved. So be careful about the angulation that you place on the cingulum. And see, suppose this is all good for tooth which are not caries affected or subjected to trauma. If suppose a central incisor is subjected to trauma, the axis cavity can be created entirely at the level of the fracture rather than sacrificing the cingulum also. Okay. Another routine issue is caries. And caries affected incisors are better to be treated after removing the caries completely and building them up. Give a stable and strong restoration will definitely help you save time for at least tooth preparation, or if at all you have to plan a post-encore and everything. Or else you can, if a fracture line is not involving too much of the crown structure, you can restore the fracture with the composite and start afresh from the cingulum reference point. Okay. This is one typical, see the picture, radiograph picture 1. This is one typical error which has occurred because of keeping the caries on without excavation. And in that endodontic therapy, the picture 1, radiographic picture 1, and endodontic therapy has been performed through the interproximal carious cavity. The first radiograph actually shows inadequate canal obturation also. And by the time RCT was initiated in this case, the caries had progressed on. And the second picture shows a large composite restoration given, axis reopened. And as you can see, there is GP on the mesial side of the root canal, while the distal portion was not touched, not clean, and not shaped. The third picture, the third radiographic picture, shows the tooth which was finally root canal treatment completed. We'll move on to upper canines, the longest tooth of the dental arch. The access cavity in a tooth where the crown is intact. Okay, where the crown is intact will begin definitely about halfway down the crown. About halfway down the crown, we are opening up the access on the palatal aspect, and the access cavity is more ovoid. In cases where there is the cusp is very much abraded, the access cavity can be created entirely at the level of the incisal surface. Okay, the prime reason for root canal of caries obviously is caries itself. And mostly after caries removal, the canals would be visible. And later on, a good build-up will be necessary. Upper canines with two canals are also seen. See the two openings seen within the access cavity, which has a typical gun barrel appearance. Having straight line access actually is very important in these cases because the tooth itself is very long and we don't want any instruments separating inside this canal. We'll move on to upper premolars. Mostly the first premolar has two pulp horns and thus two canals beneath these respective cusps. The point of entry of the burr is the middle of the central sulcus as seen in picture 2. Go parallel to the long axis of the tooth, always not the burr angulation. Then the burr is removed and it is moved actually buccolingually. Move in a buccolingual direction and out away from the tooth. And this diagram shows all the above said steps. This is depicted radiographically also. And note the orientation of the burr initially parallelly, then move in a buccolingual direction. And lastly, access refining done using a tapered burr, non-end cutting burr, and that too again parallel. So the final shape is almost ovoid for maxillary premolars. And in 5% of the cases, 3 root canals can be found. 2 thin canals in the buccal position, that is on the mesial and the distal side, and a wider palatal canal is seen. Very rarely a single elliptical canal, and a single root is also seen. That is why in the beginning I lectured on the idea of not having a predetermined shape. You will definitely not be guessing what you will find without a preoperative radiograph aligned in 2 different directions. Okay, and most reasons for maxillary first and second premolar root canal treatment are caries and periodontal involvement. So the steps for access cavity in second premolar is almost the same as that for the first. And a single root and a single ovoid wide canal is present in almost 60% cases. Others will have 2 separate canals that run into 1 or 2 separate but interconnected. So many canal variations are seen. A single canal can divide into 2 at apical third or the middle third. Do take preoperative radiographs. These are very much appreciated, and very rarely again 3 canals are seen as in the picture 3. Premolars with a single canal and a bayonet cave, that the radiograph shown downwards in the apical 1/3 is also very common. Maxillary molars, while explaining about the loss followed in access opening, I use the term except for maxillary molar, I think more than twice. True to say, these tooth will rarely give you the feel of symmetry. You can find as many as 7 in it, especially the first molars. It usually contains 4, not 3. Mind you, not 3. 4 canals, MB1, MB2, DB and palatal for sure. MB2 is actually present in 93% of cases and is negotiable up to the apical foramen in 90%. That is, I'm trying to tell you that there is a separate canal, MB2 canal, with a separate apical foramen not joining the MB1 in almost 90% of the cases. Okay, so the shape is actually roughly triangular and triangular to quadrilateral with rounded borders. And the pulp chamber floor is present slightly mesially rather than the center. So if the crown portion of a maxillary molar is actually intact, you can always begin the access opening under the mesiobuccal cusp towards the central fossa. And once the dip is felt, as in the picture 1 and radiographic picture 1, then only once the dip is felt into the root canal, orienting the burr into the center of the mesiobuccal cusp, complete the quadrilateral and complete all the dentinal undercuts remove from inside out. And if you find any difficulty in locating the canals, start with the palatal canal first, because it is the widest and the straightest, and it is usually very easy in identifying that canal. See the round burr dip into the pulp chamber, and in a see all these variations I'll talk about later. See in the first picture, see the pulp chamber, see the burr dip into the pulp chamber, and when the penetration phase is completed, slowly the residues of the roof is removed and the cavity is finished and flare using the tapered fission bed. So at the end point, I'll give you just one message. Strongly believe that MB2 is present. MB2 is always present. It is up to you whether you actually want to find it out, debride it, or just ignore it. Let it be there. I'm not going to clean and shape it. It is not my duty to. So start looking for MB2. One important point to say is that this looking for and exploring for MB2 should definitely be done only after MB1 is found, completely shaped and cleaned. This eliminates the chances of blockage while negotiating the MB2. And it will be very much necessary that MB1 is properly debrided off, because otherwise while negotiating MB2, greater chances is that you can go hit the MB1 and cause a ledge in MB1. Ultimately you will be like MB2 is cleaned and shaped thoroughly and MB1 is ledged. So don't do that. Do every cleaning and shaping thoroughly for MB1 and then go for MB2. And use multiply oblique angled X-ray radiographs both pre and intraoperatively. And the broader the route, the greater the chance that you will find another canal system also. So in this, you can actually use loops instead, and you can flood the pulp chamber with sodium hypochlorite, which will clear out the debris and make the floor clear. Then you can inspect actually and see the pulp chamber, visualize it, and then move on to obturation or other procedures. In these pictures, you can see many canals, right? DB1, DB2, MB1, MB2, MB3, palatal 2 canals, mesiopalatal, distopalatal, and great variations are noted in this maxillary molars. And it is imperative that you take radiographs at different points of your access cavity preparation also for a smooth completion of your procedure. And maxillary second molars, the anatomy of the upper second molar is very much almost similar to that of the first molar, and it is slightly smaller. The access cavity is slightly smaller and mesiodistally flatter, and the distobuccal canal is actually found halfway between the palatal and the mesiobuccal canal. Sometimes the triangle may become so flattened that all the three lie in the same line. See, that is given in picture B. Picture B, seen here, all the three major canals lie in the same line. That is also very much seen. Okay, the access cavity preparation are almost the same for maxillary for smaller. There are many variations in the canal morphology actually. It can be a single canal, it can be a double canal, it can be with 3 canals with mesiobuccal, distobuccal, and palatal, 4 canals even with divisions, additional deviations, MB1, MB2, DB2, etc. Okay, and very rarely even with 5 canals. So maxillary third molar, loss of first and the second molar may actually result in considering third molar as strategic abandonment or a medical condition that may be a contraindication to extraction. So you may have to do a maxillary third molar access cavity preparation and subsequent root canal treatment. It may be among the most bizarre and the most unpredicted of all. Again, the importance of preoperative radiograph is highlighted here, and in some case, third molar has only 1 canal, sometimes 2, 3, and maybe many other patterns can actually be seen. And going on to mandibular incisors, the lower incisors, both central and lateral incisors, owing to its mesiodistal thinness, actually pose a little bit difficulty when compared to maxillary incisors. This root, which is sometimes curved distally, has 2 canals. Again, the concept of single canal system is broken as much as to 44%. As for maxillary molars, when I said it is definitely a 4-canaled system, a lower central incisor or lateral incisor should always be considered to have 2 canals. Even if you don't find 2 canals, it will be necessary that you elongate the canal in a buccolingual shape. So the access cavity is actually initiated with a small round burr, and the burr is placed almost at 30 degrees to the long axis of the tooth. Yeah, this is a picture one, radiographic picture one, almost 30 degrees to the long axis of the tooth. You will directly hit the pulp chamber. You will feel the burr drop, and after the burr falls into vacuum, check for a patency using an 8-size file. In this third picture, see, you can clearly see that because of the presence of the already set triangles, triangle 1 and triangle 2, which are ledges which we discussed earlier, the lingual canal is being impeded the treatment. We have created the smallest access. We can be very happy. The smallest access, smallest destruction to the tooth, the canal is patent too. See, we are removing off one big canal left, debrided, non-debrided. So remove off the lingual shelf and the dentinal triangle, and we can actually see that the shape is now roughly ovoid. And this is almost similar for lateral incisor. Only difference is that lateral incisor is slightly longer. Almost the same steps follow for access cavity preparation. This is one thing which I want to highlight here. Remember, if the tooth has 2 canals in the right side, there is 100% possibility that 2 canals are always present in the left side of the tooth also. That is, again, if seen in the central incisor, big chance that the lateral incisor possesses 2 canals too. So get down your concept of single rooted mandibular tooth. Most of the cases, find out the second canal. I'm not talking about the perforation here because 44% definitely do have 2 canal system. And you find one tooth with 2 canal, you are hitting gold there. Almost all the incisors will be having 2 canals. Go on to, these are the mandibular morphologies of mandibular canine. Usually will have one root and single canal, and the access cavity is ovoid, almost extended buccolingually for straight line access, as the same for central and lateral incisor. Access cavity actually will begin midway of the crown, just above the cingulum. See the down picture which shows a case of large cervical abrasion. In such cases, cervical abrasions, the access cavity can be made entirely on the buccal side of the tooth crown. That is the only rare case where you can actually do your access cavity preparation from your buccal side and restore it properly. The lower premolars, this tooth, oh my God, is one of the most challenging ones in the entire dentition due to its anatomical variability. Where to see, and Wayne has given lots of classifications: 1 canal, 2 canal, dividing, joining, separate exiting, 3 canal, C shape, so many things, so many morphological shapes are given. The crown itself is very unusual and mysterious in lower premolar. Buccal cusp is very pronounced, and you have a flat lingual cusp, and access cavity is almost ovoid, mostly lies below the buccal cusp. So the point to be noted here is that the point of entry of the burr is in the middle of the central groove, and inclination is definitely towards the buccal cusp. See that the lingual cusp is almost completely preserved. Never orient the burr parallel to the long axis in lower premolar, as actually this can lead to lingual perforation easily. And soon the burr is replaced by a refining burr, and it is moved in a buccolingual direction again, but mostly buccally only. Sacrifice your buccal cusp, don't touch your lingual cusp. You want to widen the cavity, compromise buccal only, and lingual should actually be preserved to the maximum. Lower second premolar has single root, and the shape is also roughly round to ovoidal in 90% of the cases. And other chance are the canal being bifurcating at the apex, trifurcating, many chances of 2 canals, single foramen, 2 separate canals, 3 canals. See, the canal system is one big thing that we have to go on, because we have a certain knowledge in our mind that it is a single rooted tooth, or a single canal is the one that we are only going to treat. We'll definitely never find a second canal. So one of the biggest advantage with the lowest premolar is the better visibility. See, you can directly visualize the access cavity, and we'll have limited interference with the tongue. So it's actually kind of easy, but you should have the time and you should have the patience to find out other canals, the bifurcation, trifurcations, and all that. Moving on to mandibular first molars, the access cavity is actually initiated with a high speed round burr, and the point of entry is at the level of the central fossa. See, that is marked in green star. Orient the burr with a slight buccal direction, that is penetrate. See the slight buccal direction in the picture too, and orient the burr with that direction and penetrate the roof of the pulp chamber with a scooping out motion. You have felt the burr drop, scoop out the contents, remove the undercuts of the dentine, complete the outline form, and use a refining burr to do it in lateral movements. Mostly, the shape is kept trapezoidal. Once you feel the access cavity is done, see, once you feel it is done, try locating. If you have not found out any canals after your supposedly finished access cavity preparation, you can actually try locating the distal canal first, as that will be the easiest. And mesiobuccal canal will just well be below the mesiobuccal cusp. Follow the law of symmetry in lower molars. That is very easy. If you find a mesiobuccal canal, the following mesiolingual canal will be as much back from the midline as much as you have found the mesiobuccal canal. And if you find the distal canal in a buccal position, be sure that there is one more canal. And or if it is a large ovoid canal in the center of the tooth, well and fine. And look for some calcification or dentine blocking it if you really can't find it. If the access cavity has no walls missing, has many walls missing, do build them up so that cleaning is better with lots of solution present in the pulp chamber. And there are the variations in canal morphology. Many variations are again present. 2 mesial, 1 large distal, 2 mesial, 2 distal, 3 mesial. So many canal morphologies are present. So even 3 mesial and 3 distal has been found in the last slide, last picture. See that? The lower second molar again shows much greater variability than the first molar. The access cavity shape is almost very similar to the first molar. Only difference is in the canal types. Unusual morphology and innumerable number of combinations actually make access cavity preparation in lower second molars actually a bit cumbersome. And canal identification and debridement is a bit complicated, but the access cavity shape is almost similar to that what we have already discussed for lower first molar. Classical 2 canal system can be found, 3 canal system can be found, C-shaped canals. So many types of C-shaped canals can be found. And C-shaped canal actually was first described by Cook and Cox, and as it's actually found in more numbers in mandibular second molar. And all 3 canals may join to form one canal at the apex. And right now, anatomy and morphological part alone will take one webinar. So let us limit our topic to access cavity preparation. And however or whatever, begin under the mesiobuccal cusp. If at least 2 roots are seen in the preoperative IOPA, and extend it to distal. Or if you see only one canal in the IOPA, begin in the central fossa itself and move laterally to find out more canals. Lower third molar, again bizarre root anatomy and morphology. You will get no clue of the root canal system with its deceiving normal coronal appearance. So take IOPA, take radiographs as much as possible. Access cavity remains the same. That is, the preparation aspect is the same for the first and the second molar. And this is actually distally oriented. Most of the third molars are distally oriented, and we have a feel that the burr is actually it is going to be very difficult. It's actually the latter. It is easier to operate in such a distally placed canal. See, mostly it will be distally oriented. So we have actually finished off the shapes, and the checkpoints are: you are actually confused where to start, look for the center of the tooth. Second point, take radiographs pre and intraoperatively if you have a doubt. Place the burr and then take the radiography if you are checking for perforation. Pre-build-up is necessary for having an idea where to search, and the laws really work. So please do use them. Have a shape. You can actually modify it whenever you want. And knowledge about the canal morphology and anatomy holds first rank here. Rest of all the techniques receive only B grades. So we have lots of technology in this world. So go with the world. And you have a fear of going wrong, stop where you are. Call an expert, convince a patient. Better to give away a percentage of the money rather than to give away your sleep. That is what I feel. These are the checklist. We have actually finished with the shapes of the prepared cavity. And we'll move on to a topic, and we are already going in for 1 hour. We'll go to magnification and illumination. We'll go fast now. And magnification and illumination is actually important in access cavity preparation and almost all steps. What in access cavity? What is its importance in the access cavity is that introduction of microscope into the endodontics in the early 90s brought on a real shift. Greater technologies, greater strategies, discovering of new canal systems, so many things are there. So this is actually an invaluable tool in dentistry. And even though both the terms illumination and magnification come hand in hand, I'll discuss the first illumination first. What is the purpose of illumination? The purpose of clinical illumination is to help oral health professionals see the oral cavity and anatomic features clearly while in a working comfortable position. See, that is the whole purpose. I repeat the phrase, comfortable working position. You have light, you have to strain to see the concerned structure in the mouth, the whole idea goes wrong. In illumination, it is actually just not any light. The color, temperature and all are important. It is very usual for the clinician to open an access without the headlight being directed into the area of interest. Wrong. Illumination deficiency can actually result in many issues. One is treating the wrong tooths. Lack of illumination is definitely a problem regarding treating the wrong tooth. And if you are opening a tooth, loss of healthy tooth structure is yet another issue. Chances of missing a canal and failure to identify an anatomical variation. Now, that is the most common error. The clinician might be doing his 1000th root canal, where the illumination is improper and maybe he doesn't even have to see the tooth to open the access. But an anatomical variation, if present, would definitely be missed for even the best clinicians under deficient lighting. You have to see the area where you are working. More appropriately, I'll say flood the area with lights so that direct vision or indirect vision, you are able to see the tooth you are plating on. And muscular pain and eye fatigue actually are two greater problems associated with this indeficient lighting system. For a busy clinician, muscular pain will definitely result in less productivity, and it will definitely influence his deliverance of high quality treatment and time efficient treatment. More than that, we will actually breed ophthalmologists for sure. And these days, head-mounted lights are actually very popular. Head-mounted lights can either be worn over the head and separately from operator's eyewear or be fixed to the frame. It is actually found very cheap. I was searching through Amazon and I found almost head-mounted lights almost as much as 250 to 300 bucks starting in the range and going over to 2000 rupees. So treatment in the posterior jaw requires especially light, and good lighting is required so that you don't miss certain features. And in light of these handpieces and quadrangles with light are also present. Another instrument which can be used is the LED illuminated mouth mirror. This is found to be very ergonomic and compact. It is mostly titanium coated, and plastic forms are also available. These are autoclavable. These are very lightweighted also. Disposable mirror tips are used with reusable handles. A new design in this mirror is also found. That is, this has a 3-in-1 design. It is almost, it has light and it has a water spray, which is connected with that will not stain the surface of the dental mirror. So the instrument is a combination of 3 dental instruments. This can be used wherever required. This is the 3-in-1 mouth mirror that I was talking about right now. And The last thing here is I can call that this is a multifunctional prototype of a dental mirror that is also attached, intraoral lighting that can be used. Ultimately passing on the message that your eyesight is very important. Your visibility is important. You have to see what you're doing. And this is all about illumination. And going on to microscope and magnification, we call it microscope assisted precision dentistry. Actually, a common way to achieve better vision is to magnify the area of interest. So magnification is important. Reliable studies have shown that magnification can actually improve your quality of treatment up to almost 70%. Well, that is a wonder. And we can actually use loops or surgical operating microscopes. Loops are the most common. The magnification loops consist of two monocular microscopes, and wide ranges of magnifications are actually available, from ranging from 1.5x to 10. Many types of loops are available, simple, compound, prism loops, and all that. There's loops for endodontic procedure. Actually, 2.5x to 3.5x loops are more than sufficient. At the start, you may not be comfortable with higher magnification. That is what usually happens to all. First, you try on a loop on, hey, this is not going to suit us. This will not benefit. This is going to be very cumbersome. No, it will be difficult for everyone in the beginning. It is not first time you use it and wow. It is not going to be wow when you use it for the first time. It will take some time, and after 5x you want to use, you can shift to microscope. Actually, microscopes are available of the range 5x to 20x almost. See, both have their advantages and disadvantages. I'm not here to talk about dental operating microscopes and loops here. These are just judgings. You can actually procure these and your procedures will be more precise. But whether you actually need microscope and all that is actually very personal. See, the type of practice you have, the area you practice, the expertise you have in that field. And I will definitely be not suggesting that you charge 2000 for a root canal and your microscope what you have bought is going to cost you 1 lakh or plus. But definitely your interest and your knowledge definitely matters. So I suggest it is up to you, and it is definitely your necessity whether you actually need all these or not. Okay. And but one good thing is that, see, you can visualize it so clearly like this, and definitely you will want to do root canals on and on. That is one added advantage that is there. Last, moving on to canal location aid. There are so many canal location aids here. One, before any kind of canal location aid, the most important is definitely the knowledge of anatomy of the canals and morphology. There is a DG16 Explorer here used to identify the canal orifices, and there is a CK17 or JW17 Explorer. These are both shown. This is actually a bit different. These are all used to locate canals, and the chances that when probing, when carefully using these probes, there is a big chance that your probe falls into a canal. So that is there. Now ultrasonics in endodontics. Ultrasonics can actually trough out calcification and actually make your canal look so nice and remove your pulp stones. And you may think you have lots of burrs for it by use ultrasonics for this. The most added advantage is that they do not rotate. So they have actually very safe and has control while maintaining high efficiency. This is especially important when the risk of perforation is high. So there are many types of ultrasonic burrs here used. These can all be helpful in actually locating your canal. These are the endodontic burrs. Sorry, not the endodontic burrs, endodontic ultrasonic instruments. And along with ultrasonics, please do use fresh sodium hypochlorite. It will definitely give you best results. Now there is something else called the bubble test or the champagne bubble test. Fresh hypochlorite is poured into the pulp chamber and bubbles will start appearing from the position of the orifice. Mind you, use always fresh sodium hypochlorite, and this test is best observed through magnification. And this will definitely indicate the presence of a root canal orifice. Other things are dyes. Many ophthalmic dyes are used to locate dyes, fluorescent dye, Bengal red, methylene blue is actually cheaply available and can be irrigated into the pulp chamber. Use of dyes are actually a cheaper method for canal identification, and again best visualized by operating microscope. CBCT, intraoperative use of CBCT in complicated cases is actually indicated when you have difficulty in identifying canals, and you can actually use a small FOV, say 5 to 146 micros V. See, the ultimate point is that single tooth CBCTs are available to us in our nearby scanning areas, and is supposedly found to be on the very economical side, and it is very reliable. You can actually help, it can actually help you understand the number of canals and where to actually search for them. Like I said, it is just an aid. You cannot use them in the routine cases. Maybe it is, maybe in a complicated one or an important one for academic interest. Then the identification of bleeding points. This technique is a semi-reliable one because one, the tooth has to be highly vital. You cannot identify anything in a non-vital tooth. Second, the bleeding should not be too intense to actually not the point. It may profusely bleed, you will never get the point. And thirdly, it may just be seconds that you actually see the bleeding spot. Fourth, the orifice must be large enough to actually visualize the bleeding spot. So this is actually called the red line test. Now there is something called the white line test, and the last one, this is done in necrotic teeth. It is actually the dentinal dust which is created upon the use of ultrasonics usually, or maybe even bursts without water. This dust can actually form a white line, and you can easily identify that a canal is present. There's something else called modern access cavity preparations. I don't want to go into any details of modern access cavity preparations. We'll go fast. This is something called, there are certain terms which I would like to tell you. This one is PCD, that is pericervical dentine. What is all these terms? Leave all the terms. The most important thing is that the dentine near the alveolar class, that is the neck of the tooth, is very important for long-term survivability and optimum function. So the use of GG drills and other cutting burrs are actually discouraged. So the big aggressive canal flaring concepts is also gone in modern endodontics. No man-made material or technique can compensate for tooth structure loss. So especially in the key areas. So that is about PCD. Never compromise your neck portion of the tooth. And if you really feel that the neck portion is compromised, your tooth root canal is going to be very perfect, but the tooth crown is going to get dislodged or separated off. And there is something called a truss access cavity design. And you see here, there is a truss or a triangular shaped tooth that is left behind from the mesial and the distal cavities. You see, the prime objective in these access cavity is strategic dentine preservation. That is all. But a major drawback is that there is lack of evidence to support the use of truss. See, long-term results are yet to come. This is just the names I'm trying to familiarize you with. We are not going into details, and you really can't say whether you can believe it or not. There are certain researchers supporting it also, but it is certainly definitely up to you whether you want to practice this or go for your conventional type of access cavity preparations. There is something called ninja access cavity preparation. This is again an ultra conservative approach. See here, a small cavity is cut in the mesial side and a small cavity is cut in the distal side. These all types of modern access cavity preparations actually require magnification and illumination. You have a microscope, you can go in for all these things. You have to have ultra flexible, long, thin-handled instruments, sophisticated radiographic technology to do all these cavity preparations. Otherwise, please don't try anything of these. These are the ninja access cavity preparations. See, it is something called ninja, and it is supposed to be very small. There is again called, see, all these things, Swift MRI, Gerator microscope, and triple flex files. These are all required for ninja access and all that. You possess all these things, you have the confidence to do it, go for it. That will be good. And there is something called entry access cavity also. The canal is, it is actually again an ultra conservative approach, and it is engorged in a X-shaped. The last portion of the preparation or last portion of this webinar will be like will include almost all the possible complications of a root canal, of a access cavity preparation. So one is definitely treating the wrong tooth. Treating the wrong tooth itself is one of the major complications in root canal access cavity preparation. See, all this that can be due to inattention, misdiagnosis, over stress, and everything. But really, the patient does not want to know all these excuses of yours. He really does not care for all that. I can give you so many motivational quotes. See, mistakes are the portals of entry, and so many things like that. Please, mistakes definitely are the portals of entry, but you will have a very hard time convincing the patient and especially the bystanders about your portal of discovery. See, try not to create news in the paper that the bystander or the patient has slapped you, stabbed you, please, or else the patient must be so generous to accept your mistake. So don't ever do that. Second complication is, of course, the missed canal. Do take a proper radiograph, or you can actually take the help of technological advancements in radiography to actually identify that. Inadequate roof removal, I have already told you. Identify the roof and the pulp and debride the roof completely, debride the pulp chamber completely. The last one, of course, the most important one is definitely the perforation. Perforation can actually occur anywhere. It can be coronal, middle, apical 1/3, etc. But right now, the point conveyed is that more apical the perforation. See, if it is done apically, see the picture, the second side of the picture, the right side B. If it is in the apical portion alone, it has definitely good prognosis. And if the perforation is above the periodontal attachment, leakage of saliva will definitely be the problem, and you will be identifying it by the working solutions being present in the mouth. That will be the major sign. Cervical perforation below the periodontal ligament will give out bleeding, and that is a hallmark feature. Cervical perforation commonly occurs by locating the canal orifice and flaring the coronal third. Sudden appearance of blood from the canal is the first sign of perforation. Malaligned use of rotary burrs without actually appreciating the angle is also definitely a reason. The traditional approach for access cavity preparation in the anterior tooth is made from the lingual aspect. And this has not changed over the past 50 years, I can tell you. It is not surprising that perforation result from this approach exit on the labial aspect of the root. And see, that is due to the burr angulation, and the perforation site is likely to be located in the buccal crest bone level also. See the radiographic image here of a maxillary central incisor. See the tungsten carbide burr superimposed in the classical access cavity position. It is clear to see that labial perforation can actually occur with this kind of approach. Okay. Then the furcation perforation mostly occur in the molar, where previous restorative dentistry has been extended into the pulp chamber. This is where the law of CJ poses the most important. The burr drop feel, the law of color change, and all are important. The reparative dentine calcification. We have discussed almost all possible identification patterns of canals. So let's have one thing in mind. The treatment condition is favorable if the issue is repaired immediately, if the perforation is repaired immediately, and if it is very small. If there is healthy surrounding bone, a small perforation that is immediately sealed to prevent bacterial contamination will provide you the best prognosis. Bacterial infiltration and the resulting inflammation create the defect and destroys a good prognosis. So don't wait, or please shut down the access opening and leave the patient off. Close the perforation immediately, and immediate sealing of the perforation with biologically proven materials now with MTA and biodentine actually offers the best surface for osseous repair. And biodentine has been found to be quite economical also. This is not obtained, this can be easily obtained, I mean. So I know I've kept you a bit hard on the boredom side, and 1 hour plus I feel definitely is very hard. But I do hope that from tomorrow onwards, when you practice endodontics and especially access cavity preparation at your clinic or colleges, at least one idea, if you have found it helpful. I think the entire team that has actually put me out for a lecture here is successful. I feel that my entire team will be successful. But before I conclude, the last thing I want to say is, Just like for a treasure hunt, the topography of the land has to be known to you. You want to dig gold, you have to know the topography completely. That is, for access cavity preparation, knowledge about anatomy and morphological variations are the most important of all. You know these things, you can identify these things, consider 60% of your access cavity preparation successful. Spice it up with good quality instruments and the mindset to take multiple radiographs. Consider almost 80% done. Use technology if it is found to be reliable, and if the technology is economical, easily available, and safe, use technology. That is why it is there in the market. And do practice, be it anything. If you are not practicing, somebody else is practicing somewhere else, and he will be ready to take up your job. So experience definitely matters. So just do it, and just do it on and on. I thank my entire IDA Malabar branch, Dr. Shaju sir. Special thanks to Dr. Unikrishna K and Dr. Samira, my team, my HOD, and my colleagues, my friends, and my family. Thank you so much for listening to me.
That was very comprehensive. Doctor, thank you. Thank you so much. You have spent almost more than an hour, almost 1.5 hours, telling us about this topic. As a fellow endodontist, primarily as a consultant, I would like to congratulate you that you stressed so much on the importance of pre-op. That is one difficulty which I have faced during my cases. Pre-op x-rays, rubber dam, magnification, it all makes really a difference. Thank you. Now, looking at the doubts, actually all doubts, there are no doubts as of now. Everything is congratulating you regarding the good seminar that you did, the good webinar that you did. Hello, Doc, can you hear me?
Definitely, Doctor.
Right. Doctor, I would like to know whether you regularly use those Muntz burrs, Ellen burrs. Are they available locally in India?
Definitely, they are not available in India. These are not available. LA Access Burr, I have tried my level best to find them. They are absolutely not available in India at all. What is available is in the Endo Z Burr and the Endo Access opening burrs.
Okay, yeah, right. I had tried to procure them from, but then couldn't.
While preparing for this lecture, even I try to procure. Definitely not available at all.
Right. Okay, my dear friends, if there are any questions, please do post. This is a YouTube live stream. It will be available in our YouTube channel also. Even those people who want to get a better look later on, they can log into this YouTube channel and find this video. If there are no more doubts, Dr. Anupam sir has said that it was a superb talk. Anupam sir, pedo.
Thank you so much, sir.
A lot of other good comments are also coming. Okay, ma'am, in that case, let's wind up. Thank you so much for spending your evening, Sunday evening here.
Thank you so much, and thank you, sir. Shaju sir, I'm not seeing you. I think sir is sleeping, or he is like has left the session. Whatever. Thank you so much, Unikrishna.